Dr. Murtha, who is going to speak to us about his experience in bimanual phaco. Dr. Murtha, please.
I'm going to talk about our first experience with the new lens, Akreos AO MI 60 from Bosch & Lomb. We have no financial interest in this matter. As you know, microincisional bimanual phacoemulsification is a term which englobes mixed, phaconic, cold phaco, but the main principle is a separate irrigation instruments, and the label is phaco tip. There are two corneal incisions. Capsular X could be made by needle or forceps. Bimanual phacoemulsification, irrigation expressed in cortex through two instruments, and the IOL implantation. They have some advantage: more stable anterior chamber during procedure, prevent large changes in the IOP, the loss of viscoelastic, reduce capsular rupture. There are small incisions which heals quickly, induce less post-op astigmatism. The capture of nuclear fragments is much easier, as well the aspiration of the cortex. There are better intraocular visualization, and is a safer procedure. The disadvantage are the corneal window burns. There are a lot of studies with some modification of the power, limitation of maximum irrigation, and of course limitation of implantation of the IOL. IOL to be used in mixed procedure should be implanted through a sub 2 millimeters incision. In mixed, incision should be less than 2 millimeters because this is the limit which the induction of the astigmatism is neutral or almost neutral. IOL should not suffer permanent structural or optical changes when compressed or rolled. Should have an high intraocular biocompatibility and in-bag stability, not increase the rate of PCO, and excellent optical performance in vivo. So the objective of this study was to evaluate the new Akreos MI 60 after bimanual microemulsification through an incision of 1.8. For the eyes, for the patients, grade 2 to 4 in LOX classification system, mean age 67.8, and a follow-up on 1 day, 7 days, 1 month, and 3 months. The surgical technique were two clear corneal incisions, 1.4 millimeters, 90 degrees apart, continuous curvular capsular X's with the forceps, microincisional bimanual phacoemulsification with legacy Alcon, irrigation aspiration of cortex with two instruments, and the IOL implantation with counter pressure with a final incision of 1.8. Total surgical time around 10 minutes and 15. This is the new Akreos MI 60. They have two parts: the central part with the stable zone and the absorption zone with the four haptics in the periphery. The design of the optic is adequate for an incision less than 2 millimeters. This is an spherical aberration-free design, 360 degrees posterior region square edge, and 30% thinner than the anterior design. The optics has three-dimensional stability, 4-point fixation in the optic in the capsular bag in 3 dimensions. The overall diameter varies, like we are going to see, with the range of diopters, angulation at 10 degrees, and the innovative shape of the optics. Like we see here, the conforming tip, they will bend as the capsular bag will stretch, like we see here, like we can see here in this. No? The video doesn't go?
Click over.
No. But I don't have the hand. Oh, okay. So, over time, with the capsule, the contraction of the capsule, the tips will bend anteriorly. So the overall diameter of the lens differs and the optical zone from diopters. With less diopters, more myopic the eyes, the higher the overall diameter and the optical zone. And it's necessary to wound-assisted injection to do it for 1.8. There are some methods that inject it for 1.5 or 1.7, but I think it's too difficult. And to minimize the corneal stress, the internal cartridge diameter must fit the incision side, not introduced in the incision size, and the hydrophilic nature of the lens and the softness help to preserve the corneal integrity. This is the I move here at the end part of the Bimanual microphacoemulsification, the aspiration of the cortex, and then we see the preparation of the lens, 1.8 of incision, the lens, and this is one of the main, I think, disadvantages of the lens. Bosch and Lomb is now preloading the lens within injector, because sometimes it's difficult to put the lens in the injector. There is a click when we close it, and then the introduction, the cartridge in the injector, and to put it in the incisions, we should put it in the tip of the cartridge, because if no, with a lot of pressure, we can have some problems, and we inject with counter pressure through 1.8, less than 2 millimeters of incision. Like you can see here. After the end of the procedure and the aspiration of the viscoelastic. Okay, this is the end. This is then corrected visual acuity and best corrected visual acuity. There is some differences, like you can see in it's a lower uncorrected visual acuity, and we think that there is we overcorrect in these patients. Normally at the beginning they became myopic, so at this moment we undercorrect about half a diopter in the pres-op, and all of them were, the biometry was done by the IOL master. The mean induced astigmatism is lower, like you see. Flare cells in the anterior chamber. There is at 3 months no deposition of cells in the surface of the IOL. There was an excellent stability of the IOL at 3 months follow-up, and no posterior opacification at 3 months. At the beginning there was some wrinkling of the posterior capsule, but disappear after some time. We see here that a good stabilization of the lens, even the capsule rest is not concentrical with the optical zone, this with the eye magnification, and 3 months post-op, a good stability of the lens, no posterior opacification of the capsule. So as conclusions, it's necessary a large, serious, and longer follow-up, but the new Akreos MI6 seems to be an accurate and safe IOL, which can be implanted through 1.8 millimeters incision using a wound-assisted injected technique, which minimizes corneal stress. Thank you.
Thank you, Dr. Mutta. Next, I'll invite Dr. Deka. She is going to tell us her experience about a new intraocular lens which can be inserted through microincision. Dr.
Thank you very much. A 400-patient study on